Meg from the Good Things Foundation. You'll see on the screen some housekeeping points, but Jo, do you just want to run through those for me, please?
Yeah, sure. Hello, everybody. Really good to have you here. As you'll have just heard, we are recording these sessions, and the recordings will be made available via our website after the event, and we'll send you a link to those in case you want to access them again. If you do have any concerns about the recording, please get in contact with us after the event, and we can talk through that. You'll notice that your cameras and audio have been disabled if you're unless you're one of the speakers today, and that's just to make sure we can protect people's bandwidth and have the best kind of experience for the presenters today. But please do use the chat space for comments, for questions, for engagement. We'll be collating the questions that are from the chat throughout the seminar. And there's space at the end of the seminar for a Q&A with the presenters. So please, if you've got any questions for our presenters, please pop it in the chat and we'll collate those and hopefully have time to put a few to the speakers at the end. And then finally, if you would like to use closed captions or live captioning, please, that has been enabled, so you can access that by clicking on the 3 dots and more symbol and then click captions. On my screen, that's on the bottom right hand side of my Zoom panel. Thank you very much.
Brilliant, thank you, Jo. Let's get started then. So just a little bit of background about the Health and Wellbeing Alliance and us as a charity. So the Health and Wellbeing Alliance is a group of voluntary and community sector organisations that work collaboratively with various health system partners. So by that we mean Department of Health, NHS England and the UK Health Security Agency. We help them and support them by providing access to groups of people who they are trying to engage and understand the needs of. But we also help by developing projects that are part of the Alliance work. And you can see the policy areas that are priorities on the screen there. Our focus spans so much work that this is one of our attempts at drawing some of that work together. We are, let me just talk a bit about us and then I'll talk about the session. So Good Things Foundation are the UK's leading digital inclusion charity, and our mission is to fix the digital divide. We do this in 3 ways: by providing support to people through a national digital inclusion network. We have hubs across the UK that number in their thousands, and they provide local level community-based support for people who want to become digitally included or even just want to do something online and don't know how. And through that network, we offer skills support through our learning platform called Learn My Way. But they do a lot of other informal support to help people get online. We also provide the National Data Bank and the National Device Bank, which is free access to mobile data and devices provided by some amazingly generous partners to help people resolve any access issues that they've got to being online. So we work across the sphere, but we're also very keen to kind of help others do digital well and help make their products and services as accessible as possible. So today's seminar is part of a series of 3. This seminar series is about drawing together the digital inclusion learnings that we have all learned, many of us at voluntary and community sector organisations across our work of the Alliance. Many of us has been running projects in the last 2.5 years. All of us have, and many of them have got quite detailed reports behind them, but there are lots of similarities but some differences between what we're learning. So this is an attempt to draw some of those things together. This is the second seminar in the series. The first one yesterday, which some of you may have been at, was about exploring the intersection between digital and health inequalities. That was recorded, and if you weren't able to attend yesterday and would like to see that content, we'll let you know when that's published. Today's seminar is more focused on the barriers that exclude people from digital health services, and then tomorrow we're looking at more practical tips in terms of designing. Again, we're fully booked for tomorrow, but the session will be recorded, so if you're not already registered on that, we can make that available to you afterwards as well. Yesterday, what did we hear? Well, we heard that it's really important to know which groups are at risk of being excluded from your services, and there's lots of data and information out there. We also heard that digital services and system design can create or exacerbate existing health inequalities. And it's important to make sure when you're designing your services to make sure that digital is indeed a helpful solution to the audiences that you're supporting. Or if it's going to cause more barriers. If it's going to cause more barriers, then it might not be the route for you. That digital inclusion is promoted in health and care policy. There is a policy context. So if you need to make a business case to move to kind of create a digital element of your services, there is a backing, at a policy level for you to make that case. And then finally, one of the key points that came up yesterday was to consider the cost to the end user of accessing your services. So do they need to buy the tech or not accessing digital services, so being further excluded from products and services and access? They are just highlights. There was lots more said yesterday. It was an hour and a half session, so please do go back to the recording, and the slides will be released as well. So today's session, which is, as I said, exploring in greater detail some of the barriers that people face to accessing health services, and we are using some of the guidance that we talked through yesterday, but I'll recap some of that. We're really delighted to be joined by colleagues from Hospice UK, the Equality Foundation and Barnardo's today, who will all have a session later on to give you their perspective on the populations that they represent and the learnings that they've gathered through their digital inclusion work. This is how it's going to run. So you're going to hear more from me at the beginning, which you're very lucky about, and I'll run through some of the more common digital exclusion barriers. And then we'll hear from Jamie at Hospice UK, Jabir and Johan from Race Equality Foundation, and Natalie and Karen at Barnardo. So hopefully we'll keep to time, we'll whiz through that, and then we'll have a space for Q&As at the end of the session. Joe and Meg from Good Things Foundation will be collating your questions and we'll summarise them. We will also provide you with contact details for the presenters at the end. So if your question is not asked, you will have the details of those presenters so you can go away and ask those questions on the side. Okay, Joe.
Thank you, Katie. So just before we get started with Katie's presentation first, we're really keen to know a bit more about who's here today observing this seminar. And this is partly for our understanding to get a better picture of where we're sharing our insights. And also we'd like to do a really quick and dirty assessment of how the information from this seminar lands with you. So we've got a quick poll that we're going to do right now with 3 questions asking you which sector or field you work in, how much knowledge you feel you currently have about digital inclusion and access to healthcare, and also how capable you feel to identify ways to improve digital inclusion in healthcare. And then what we'll do at the end of the seminar is we'll do a repeat of the second and third question just to see whether there's any change in your knowledge or confidence. So I'm going to launch the poll now, what you might need to do is scroll down on the screen to get to the second and third question once you've answered question number 1. So we'll give you a minute or so to answer those 3 questions, but remember to scroll down through the panel. See the numbers coming in thick and fast, which is great. We'll give it a few more seconds for you to answer the questions. Nearly there. 10 more seconds. Okay, that's great. Thank you very much for your time on that. I'll end the poll now. Over to you, Katie. You're on mute.
I did exactly the same yesterday. I have obviously not learned. Thanks, Joe, for that. And obviously, as Joe says, it's quite a crude measure, but hopefully it'll help us give some good data in terms of the outputs of this these seminar series. Okay, fantastic. So I have got just under 15 minutes to talk you through the barriers that exclude people from digital health services. Now, at Good Things Foundation, we work really hard to kind of remove these digital barriers, but it's important that we share with people a much wider audience in terms of what these barriers are. It's easy to forget if you're not looking at them every day. So even if you've heard them before, it's useful to be reminded of. So just a bit of a recap in terms of what we talked about yesterday, for those of you who were there, and for those who weren't there, this was a kind of a kind of good bit of background. So services are moving online all the time. We know they are. You know, they save services money, and that you know there's nothing wrong with that. But by not considering those people that are digitally excluded, we find that they may struggle to access jobs, education, participate socially, access health and wellbeing services, or benefit from the savings that people can make online by doing price comparisons, etc. We know that 1 in 14 households do not have access to the internet, and that's 2 million households don't have access to the internet. So it's important when you're designing your services, if you have a service that you want people to use at home, think about those that don't have that access and how you might overcome that. And that around 10 million people lack those basic digital skills. Now, we talked yesterday about who those people are. Many of them are over 75, but that is not exclusive. It spans all age groups, and there are many young people who have very limited digital skills, especially if they're only used to using a smartphone. They may not be able to use anything more complex than that. So there are many people that might be excluded if you move your services solely online. And then these are some of the people that are most likely to be excluded. So those people with a disability or a health condition. Given our audience today that we're talking about digital in healthcare, it's really important to consider that a lot of the people that you may be targeting your services at might be the ones who are most digitally excluded. Like I say, they're more likely to be over 65 and especially over 75. Actually, they are the kind of most excluded population, maybe from low income households as well. So considering your core population, your core audience of any healthcare product or service that you're moving online will mean that you are considering people in these populations and large numbers of people in these populations. So considering whether digital only is a solution for you or whether it's digital as part of a wider solution, it definitely needs to be part of your conversation. So we look across lots of bits of evidence, and these are the kind of core barriers that come up again and again and again. Those of you who are close to digital inclusion will know that some of these themes are overlapping and put together in different groups sometimes, but you know, essentially these are the things that are at the core. So we're talking about access. So do they have a device or data? Skills and confidence, which we've just talked about. Motivation. Some people just don't want to be online, and that's okay. Feeling that you can trust or feeling safe online is a big barrier for many. For those people that are living in more unstable circumstances or houses where there's lots of people, finding a space to use the internet is a challenge. Having the right support around you. What if you forget how to use something? Who do you ask and how do you go back to that? But then also having independence, choice and control, feeling like it's within your gift to make the decision to go online rather than being forced to do that. So I'll run through all of these in a little bit more detail. In terms of access and space, just keeping an eye on time, like I say, this is about having a device or mobile or broadband access. And that includes sufficient data to access digital services. So many digital online services may drain people's data, and therefore they may be cautious about using the sites that you're pointing them towards for fear of that. It's also having enough minutes to make calls. If they're being put on hold to be able to access services, that might drain down their minutes as well. Many people talk about being on hold for 45 minutes, 50 minutes. We're just trying to make a GP appointment, and that is a big consideration. Also, having a printer or easy access to a printer may be useful, certainly in a healthcare setting, if they need to print something off to kind of make a record of something. In terms of space, physical space, I've talked a little bit about this previously, but living in overcrowded housing means there is limited private space. Living in an abusive home may mean that you don't feel comfortable being able to be open and honest. If you're trying to have a healthcare conversation and there's lots of people around you and you're trying to discuss something that's quite private and personal, that doesn't work for you. So pushing people online is not always the best route to go. Maybe thinking about providing more private spaces in your healthcare settings could be a solution. In terms of skills, confidence and motivation, there are a number of frameworks that lay out what these basic skills are, and the Essential Digital Skills Framework is one, for example. And the kind of things we're talking about is having an email or a social media account, can find and download an app, can use a search engine, understands what the padlock sign means. These are really simple things, but can be real barriers if people don't really understand what they mean and how they do them. And the overlap can be with things like basic literacy and numeracy, language proficiency, health literacy, and media literacy. So all of these 4 things working together, if they don't have one of these, it makes it a challenge. But imagine if they don't have all 4, it moves them further and further away from using the digital products and services. In terms of motivation, some people have concerns about digital services replacing face-to-face or phone in general. Many people, especially elderly people, use that kind of face-to-face support to overcome some of their isolation and loneliness. And it's a really important part of their day, a visit to see a healthcare professional or pop into the shops. So thinking about how you build in that contact is really key. And also lack of belief that a digital service will give them a better or faster outcome. We've all been there, haven't we? Going through those pages of forms just to try and get an appointment or a price for something. Actually, if people believe that it's harder than just talking to somebody face to face, then they won't step into that space. And again, this leans into the lack of support. So if they've not got anybody to reassure them and support them, then they're less likely to step into that digital space. In terms of support, independence, choice and control. So we just talked a little bit about support, but there is a positive relationship between internet use and confidence and people's personal social relationships. Our National Digital Inclusion Network is a prime example of kind of how this model particularly works well. We have a network of community partners that are there, and they are a trusted face in a trusted place where people can go and find the support that they need, ask the stupid questions that they don't know who to ask, and go and find somebody who can talk them through patiently the step-by-step process that they need to do, and that they can ask again and again and again. If they go away from the session that they've been in and forget, it's okay to come back and say, oh, I can't remember what you told me last time. And we see many people requiring many hours of support just to do simple things and kind of build that confidence. We also saw a drop during lockdown, actually, of people's skills and confidence. And we think this was mainly due to the fact that people didn't have this reinforcement place to practice and the kind of ongoing support to kind of just check in, am I doing this right? Independence, choice and control. Keeping all channels open to services is a really essential part of building trust and support for people who may be digitally excluded. So it saves, like I said earlier, moving services online saves services money. It absolutely does. Not having to have a reception desk full of 5 people to deal with everybody's queries is cheaper if you move stuff online. However, there are concerns about online harms and that transition. And so giving people the ability to choose where they want to be is absolutely fundamental, and kind of really does build trust in your products and services. And then finally, trust and feeling safe. There are many people who mistrust technology generally. We heard some great examples, or some quite concerning examples yesterday from organisations that were representing communities that were migrants, for example. We heard from friends, families and travellers yesterday about concerns about the system as a whole, about sharing data with the government. And so thinking about how you build that trust, reassure people that their data is safe, show them how it's going to be used. And if someone's got lack of trust in their own abilities to use the technology, that can also be a barrier for them as well. So, it's all of these things working together make it much easier for somebody to access products and services online. But you can see why it's easy for somebody to be digitally excluded. Just one of these things not being in place may mean that they are excluded from that world. And thinking all of them through as you design your products and services is absolutely key. How we might enable or remove these barriers? Well, one of the key elements of this is emphasizing the positives. Digital options really can remove some barriers for some. So there was an example yesterday from the NDTI about some autistic populations actually finding digital access to services more empowering, and made them feel much safer in terms of that interaction through a Zoom call or a telephone call rather than face-to-face. Face-to-face appointments often can be anxiety inducing. But also getting people involved in the design of your services means they're more likely to meet their needs, bringing them along with you, asking them what they need, what doesn't work for them, does this make sense? Can you follow the process I put in place? Things to watch out for. Making sure you keep multiple routes open for access to your services, so online and offline. Whilst it might be easier for you to operate online, then the offline route is often preferred by many. Barriers to digital services can compound existing non-digital barriers, so we talked a little bit about that yesterday. Technology and access is constantly changing. So being ready to adapt your approach for an individual when a new service comes online is really key. AI is a really great example of that. It's a real buzzword at the moment, but many tools that might be put in place might need a lot of explaining and coaching of people to bring them on that journey with you. Consider digital inclusion and design as part of your service. So addressing the barriers that can make services more accessible is absolutely key. And then think about who is providing the support when you put these services in place. My watch has just buzzed. This is my last point. That's not bad, is it? So yeah, think about those kind of frontline staff members who will be providing that support. Even if you think your product, your service is designed in the best way possible, there will be one person that goes back again and again to ask that receptionist, that voluntary and community organisation, family members to help them use it again and again. So that kind of impacts on people's ability to come in again and use it over and over again. And that's the end of my section. Phew. So if you have got any questions, please pop them in the chat and I will come back to them at the end if we've got time. If not, please do get in touch and we're more than happy to come and talk to you more. Keeping us to time as best as possible, I'd love to hand over now to Jamie from the Hospice UK, who's going to talk us through some of his slides. Jamie, I will drive the slides, so just tell me when you want me to move on.
Thank you, Katie. And as somebody who's spent the last 3 years redesigning the Hospice UK website, I can vouch for some of the points you made on that very last slide about making sure that users are at the heart of all of the design work that you do when building a new digital tool. So thank you very much for having me here on the call today. Just as a brief introduction about Hospice UK and why we're here today, we're part of the Palliative End of Life Care Consortium, and that's a consortium that includes teams like Marie Curie, Together for Short Lives, and the National Bereavement Alliance. Hospice UK conducted the work on the digital inclusion, which involved desk research, interviews with key informants from the King's Fund, the Helix Centre, and NHS England Virtual Wards team. And we also spoke with many hospice representatives about their experiences of delivering virtual services and, in turn, the feedback they received from service users. Now, a policy brief containing our key findings, which has been driven by our programme development manager, Catherine Hodge, who is very much at the heart of all of this work. That contains our key findings and 2 case studies, which has been approved now by HWA policy leads, and that will be published on the Hospice UK website in the coming weeks. So keep an eye out for that. And next slide, please, Katie. So the first area that we're going to look at is health inequalities. So if you can move on to the next slide, please. So again, and none of this will be particularly surprising, I think, to most of you on the call. You will have some knowledge of health inequalities in the UK, not least from yesterday's digital inclusion webinars. The recent data from England shows that people living in the least deprived areas of the country can expect to live on average around about 18.4 more years with a good general level of health than people who live in the most deprived areas of the United Kingdom. We know that people living in the most deprived areas have shorter lives and spend more time living with diagnosed long-term illness, which of course is an area which then brings us into the area of hospice and end-of-life care. So if you can move on to the next slide, please, Katie. Thank you. So again, none of this should be particularly surprising to people. Some communities, they continue to experience inequitable access to hospice care, particularly groups like the oldest people across the country, again, building on Katie's points from her earlier presentation, racialised communities, people who have illnesses that aren't cancer, people living in rural areas, and people living in areas of high socio-economic deprivation. They have already been negatively affected in all probability by health inequalities throughout their lives. Hospice provision in particular can be very geographically dependent. Some areas, such as London and the South East, have numerous hospices, and although they take great care to try and make sure that their catchment areas don't overlap, there will sometimes be that overlap, so that some patients might potentially have a choice of where they can get their hospice care from. But there are other areas where there will be huge geographical catchment areas for hospices, for example, in Scotland, Highland Hospice, or in the southwest of England, Cornwall Hospice, which has a catchment area of nearly 1,300 square miles. And where there are no hospices, palliative and end-of-life care is delivered by the NHS, but there can be a great deal of geographical variation. So if you can move on to the next slide, please, Katie. So how can digital tools be useful in hospice care? Thank you. So, first of all, digital tools and services have the potential to help hospices deliver care outside of the building in a much more equitable way. That will allow for the rurality of the person that they're caring for, the transport links that they may have, those poverty concerns that people might have about the cultural safety, the infection risks of hospice buildings, for example. Out-of-building care is not the exception for the hospice sector, and we know that the demand on palliative and end-of-life care is going to increase rapidly, we expect, over the next 25 years. However, fewer than 5% of those people who die each year die in a physical hospice building. Most of the care that hospices provide is delivered outside of that hospice building. Over 300,000 people cared for by a hospice each year, most of that care delivered in the place where they would ordinarily reside, such as a private home or a care home. And hospices, it's crucial to point out, are not just there for people in the last days of their lives, but for people living with all sorts of complex conditions and difficult symptoms. And sometimes that care can last for months or even years of that person's life, including bereavement support for people whose loved one did not die in the hospice. You can move on, Katie. Thank you. So again, the pandemic, that obviously COVID-19 showed us that digital services can be used to deliver hospice care, and in all sorts of different ways. Catchment areas, as I mentioned earlier, covered by hospices can be extremely large. People having to travel very long distances when they're very unwell. A particular challenge in remote and rural areas where, as you can imagine, transport links are not as good as people who might be living in cities. COVID-19 restrictions led many hospices to start delivering services virtually. Outpatient services, breathlessness and art therapy groups were being introduced by hospices across the country. Some introduced psychological support and welfare advice. And those digital tools were being used to track the symptoms of people being cared for at home in real time, making it much easier for community teams in those hospices to prioritise caseloads and help those people receiving care and those caring for them feel much more in control. It was about delivering that help and making people feel that they controlled it rather than being told what was going on by somebody else. If you can move on, please, Katie. So again, how are hospices doing all of this? Well, the research shows that the use of digital services in palliative and end-of-life care is still in its relative infancy. But some of the ways they're currently being used include the ones on the slide: remote consultation, so people not having to travel those potentially hundreds of miles to a hospice, getting that consultation being delivered in a remote way; virtual wards; remote symptoms and outcomes monitoring; bereavement support services in particular, especially for those loved ones that have been affected by a bereavement; outreach services for people living with long-term illnesses; and facilitating multidisciplinary and multi-agency working. And our recent data from our member hospices suggests that around about 40% of hospices around the UK, so around about 80 to 100, are currently offering some kind of virtual service. So let's look at some of the barriers to inclusion that we've got in the hospice sector at the moment. If you can move on to the next one, please, Katie. So the Good Things Foundation has identified 4 key elements that can determine whether somebody's being digitally included or excluded. Some people are excluded due to an intersectionality of these elements as well. That's crucial to point out, because it might not just be one skill that somebody lacks, but it may be that they have some of these skills or these things that connect them, but they actually find that there's another problem getting in the way. So, for example, people living in rural areas may have the appropriate device, for example. They know how to use it and they want to use it, but if their internet connectivity is terrible, they're excluded from that service. On the other hand, a person may have access to great internet connection, but they're excluded because the tool's inaccessible to them and they do not have the skills to use digital tools and are not motivated to acquire those skills, because the inaccessibility in the first place has led them to believe, understandably, that there's no benefit to them using those services. As Katie pointed in her presentation, 10 million people lack those basic digital skills. That's a major barrier for some people accessing digital tools. So if you can move on to the next slide, please, Katie. So people accessing hospice care are often members of groups that are particularly vulnerable to digital exclusion, including people with disabilities and people who are older. Accessibility may become more of an issue as people's symptoms burdens increase over time. People who live far from a hospice building in rural and remote areas, who would greatly benefit from those remote services, are also more likely to be digitally excluded due to connectivity issues. Although it's not a complete truism, the further remote or rural a person is, the less likely they are to have access to really fast broadband. As Katie mentioned earlier, 1 in 14 households have no internet access at all. Hospices are often using different IT systems to other providers in their health and care systems, so they don't have sustainable funding available to invest in infrastructure projects. That can render digital services unavailable, and sometimes they can be seen as anachronistic, clunky, and inaccessible. For example, people may have learned the digital skills they need to use a digital service or tool provided by their local GP, but then they have to transfer to another different system provided by the hospice. And access and security, as Katie was pointing out earlier, can also be a particular challenge towards the very end of life, as people's diminishing capacity may mean that unpaid carers, district nurses, and social care staff need to access the tools to report symptoms, etc. The pandemic meant that there was a lot of solutions developed in a very reactive way. And sometimes that meant that those design principles and inclusion of service users in those development processes were sometimes skipped. And that, I think, was crucial. It's not only service users who are at risk of digital inclusion, but also staff, especially when multiple providers are working with a hospice to deliver care, as is often the case in the local community. Now, I'm conscious time is moving on, Katie, so I'm going to race through the recommendations, and obviously this will be available for people to access after the presentation as well. So the following section contains the recommendations from the policy brief itself. So I'm just going to run through these quickly. So first of all, the recommendations, the top tips for all providers: take time to understand the needs of people at the end of life, carers, staff, volunteers, when designing and using digital solutions. I mean, that for me underpinned every bit of the work that I did on the Hospice UK website. We did that at the very outset. Encourage collaboration and shared learning between providers to prevent duplication with specialist organisations, to hopefully increase those digital skills, confidence and trust. Support and invest in people who are passionate about adopting and promoting digital health, and invest in the digital skills of staff. Sometimes it can be that they lack the confidence to reach out and say, actually, they need a bit of support in that as well. and also provide that online and digital service in an appropriate community language if it's required, and accessible formats. You know, if your community has a particular requirement, make sure it's designed around that and ensure that it's meeting the accessible information standard. So moving very quickly on to the next slide, which is not the easiest to read. I'll give you that for PowerPoint or for Google Slides. This will be in the policy brief and it can be sent to anybody who would like it. Just ask them to email us at Hospice UK and we can send that through. I, as you may have gathered, would find that point one here is the key one. Define the problem and the people that you're trying to solve the problem for. That lies at the heart of everything. So finally, some system level recommendations. Allocate adequate digital health funding to providers and networks, including for crucial basic digital infrastructure within the hospice sector. Invest in digital skills training for staff across the health and care system, and support providers to maintain in-person options while developing digital services and connect them with that expertise from beyond the health and care system. And that brings me to the end really of my presentation. So apologies if that was a bit of a whistle-stop tour across the hospice sector and digital inclusion. And thank you very much for having me on the call today.
Brilliant. Thank you so much, Jamie. Yes, slightly over time, but we're good. We got a little bit of space in today's session. And great, thanks for kind of connecting together the themes across the two sections. So like Jamie says, all of this stuff will be available afterwards. We will be putting all of this on our website, the recording, as well as the slides and the takeaways. So, and you now will have Jamie's contact details at the end of this, so you can kind of get in touch if you want to discuss further. But any questions? Oh my goodness, my screen's my computer's just decided to do an update. So just bear with me. Let's just go back into the slides. Apologies for that. Okay, fab. So without further ado, let's hand on to Jabir and Jahan from the Race Equality Foundation, and they're going to talk us about digital inclusion for people from ethnic minority groups. Fab.
Thank you, Katie, and thank you, Jamie, for those excellent presentations. Hopefully, I can keep up the pace as well. Could we go to the next slide? A little bit of advertising for the organisation first. For those of you who don't know us, the Race Equality Foundation is a national charity led by Black, Asian and ethnically minoritized people. That is an evidence-based organisation that tries to develop policy and practice to tackle racism and racial inequalities. Our vision is a society without racism, and our mission is to tackle racism in UK society and positively transform the lives of our Black, Asian and ethnically minoritized communities. Could we have the next slide, please, Katie? Those of you who are interested in some of our work can go along and look on our website. But that work ranges from a community-based approach to improving blood pressure monitoring, a large number of briefings on the latest evidence around discrimination and disadvantage, things like policy review and evidence review of mental health disparities, as well as a lot of work around the impact of COVID-19 on minority communities. But in terms of thinking about what we're here to discuss today, I just wanted to take us a step back. In a conversation I was having with one of my children, I tried to argue that actually the invention of the flushing toilet and the production of sewers perhaps had as much of an impact on improving health as antibiotics. The truth is he remained very skeptical, but I think it's important for us to try and think about what's happening in terms of digital transformation along those lines. It's not necessarily what's obvious in terms of what it does around improving healthcare, but it's what it does in terms of the overall impact on well-being. That's going to be important. Some of it is superficial. Facebook tells me that I have 260 friends. My children will very quickly point out to you that I have 2 or 3 friends, and then that Facebook is clearly wrong. And it's important to not get confused by those superficial things, to actually understanding what the possibilities of digital development and digital inclusion is possibly going to do. The opportunity to democratize access to information is a key part of trying to improve people's health and well-being, and I think we should think about that. But all of that has to be placed in the evidence on ethnic minority groups facing barriers in healthcare access and resulting in poorer health outcomes. Some of you will have seen that we were part of a consortium that produced a review of the evidence on the experience of Black, Asian, and minoritized ethnic people with a learning disability. And part of the data demonstrated that while people with a learning disability had a lower life expectancy than the general population, something like a 16-year difference, there was actually a difference in life expectancy between minority communities and their white counterparts as well, somewhere in the region of 14 to 16 years. So Black, Asian, and minority ethnic people with a learning disability were dying even younger than their white counterparts. And that picture, unfortunately, is replicated too often in other areas of the experience of health and well-being. And we need to ensure that when we start thinking about digital exclusion, that we understand those systemic problems in service operations and that we address those. One of those is the continuing challenges around representation of minority ethnic workers in the workforce. Research also indicates, when we're thinking about digital, research also indicates that ethnic minorities and older individuals are less likely to use health apps and express concerns about data usage. Katie's already presented some of the evidence around digital exclusion and how minority communities and refugee communities are impacted by that. But there's also a sense that there may be other aspects, particularly age, that acts as a barrier. We did some work looking at the availability of apps to help South Asian communities manage their diabetes, and discovered that there was actually very little available. And those attempts that had been developed across the world often failed because of the fact that the target group didn't actually have access to the types of smartphones that would allow them to make use of those apps. This comes on top of a number of issues such as mistrust of data use by government organizations, lack of digital literacy, language barriers, and so on. And I'll talk about that in more detail now. Katie, do you want to move on to the next slide? Trust is regularly raised by Black, Asian, and minority ethnic people in terms of their relationship, particularly with state services. And healthcare isn't immune to these worries about trust. If we look at the take-up of mental health services, we know that a lack of trust in what's going to happen ends up meaning that people wait till crisis before they actually approach a service. And inevitably that waiting until crisis leads to poorer experiences and poorer outcomes as well. There's also continuing worries about the lack of representation and what that means. However, a point to be made here that representation on its own doesn't necessarily lead to better outcomes. We know, for example, amongst midwives, Black, Asian, and minority ethnic midwives are there in significant numbers, yet the poorer experience of particularly Black mothers is still there, and it clearly points to the need for systemic change as well. Can we move on to the next slide? There's also an issue about the lack of digital literacy as well. I'm old enough to remember when we didn't have the internet, when we didn't have email, when we didn't have smartphones. But it is the case that there are, particularly in the generation that it would now be described as being older, those people over the age of 65, where there continues to be lower digital literacy. and the heavy reliance on digital navigation is going to prove to be a real challenge, including the limits on engagement with healthcare decisions. One of the challenges we found during COVID-19 was to actually get data on who was accessing services through the digital doors that were being opened, whether it was for mental health services, whether it was for people who were living with dementia. It was never quite clear whether we had that data to show whether it was open to everyone and whether or not people were using it in the same way. Could we move on to the next slide, please? Inevitably, language barriers come up as a real challenge. The lack of available interpreters results in reliance on family and friends, and that continues to be a problem. We're now seeing digital translation being used as a way of overcoming that challenge, but we don't have any evidence on the efficacy of that. Is it better? Does it work? Do people feel confident enough on it? And yet are still things to be answered, and we really do need to understand that before we start using it as a replacement for translate interpreters. And importantly, that still has to address the cultural differences that might exist in effective communication. We still need to make sure that healthcare professionals who are using those tools are using them in a way that actually encourages engagement and communication. To move on then in terms of policy recommendations. Sorry, Katie, the next slide, please. It's important for us to demonstrate commitment to tackling racial inequalities in healthcare. Many of you will remember when the NHS app was first released during COVID-19, it didn't ask you to record your ethnicity. That eventually came, but it wasn't there to begin with. And it wasn't because organizations like ours didn't advocate for it. It was that a decision was made that this wasn't possible at that time, and may act as a deterrent to people joining. Yet it's crucial if we're actually going to understand who is using these tools and so on. So it's important for us to demonstrate that change. We certainly need to provide community digital literacy support through targeted approaches. Some of the work that Good Things are doing are really important, but some of the work that people like the Asian Disabled People's Alliance are doing really works as well. The time and effort they put in helping people navigate the system and to be able to use the tools that are available are key. Establishing relationships through co-production are important, and inevitably we would emphasize that ensuring that equality impact assessments are carried out so that we do understand the changes we're making and the impact they're going to have, and if needed, have take actions to ameliorate any negative outcomes. Thank you very much for listening.
That's fantastic, Jamir. Thank you so much. Really appreciate you running us through that. I'm sure that's raised loads of issues for many of you, so please do continue to drop your questions in the chat and we will collate as many as we can and get through as many as we can at the end. Fantastic. So I am now, for our last case study in this session, really pleased to pass over to Natalie and colleagues at Barnardo's, who will talk you through the work they've been doing on digital inclusion for parents and carers and families.
Thanks, Katie. I will start with a very brief introduction to Barnardo's and particularly our role in child health and the work we do to tackle inequalities. So if you can move on to the first slide. So Barnardo's services work across prevention and early intervention, really addressing those wider determinants of health, and we're working across the community with health and education to provide services to support the health and well-being for babies, children and young people. And there are a wide range of services that Barnardo's deliver across the UK. It's far too many to talk about in our time slot today, but I would encourage you to take a look at the Barnardo's website or perhaps get in touch with me to find out more. For example, we've got our early years support services, our family hubs, children's centres, mental health support programmes, as well as a range of child health equity work, to name just a few. Next slide, please. So as part of our health inequalities work, Barnardo's is a member of the VCSE Health and Wellbeing Alliance, and within this, Barnardo's leads on the Children and Young People's Consortium. And this is made up of a range of grassroots, community-led organisations who provide a real range of different services, predominantly to families from Black, Asian and ethnic minoritized communities. And they're supporting some of the most deprived communities and often marginalised communities across England. Last year, the Barnardo's Consortium led a project on seeking to find out more about parents' experiences of digital exclusion. And this was at a time when we were just emerging from the pandemic. So our consortium were really well placed to provide that insight into how small organisations were having to change the way that they were delivering their services during the restrictions throughout the pandemic. Next slide, please. So the Good Things Foundation's report has already been talked through within this session many times, so I won't talk about that in any great detail, but I think just to add that this really helped to inform our own work in this area. But at this time, there was very limited insights into the digital exclusion being experienced by parents specifically. So this project really set out to explore two kind of key lines of inquiry. So thinking about what health offers do parents or carers prefer to access online rather than in person, and what are the primary enablers for digital inclusion amongst families, particularly those living in poverty or from marginalised groups. Next slide, please. So to begin with, what offers do parents and carers prefer around accessing online? There were a number of valuable aspects that they identified. So often looking online is a first port of call for parents. So in particular, using an online search prior to speaking with a professional is seen as really valuable. And also the speed of this. So thinking about online information as a really fast way to accessing health information, and the fact that that's available 24/7 is really valuable for parents. And I'm sure a lot of you will be able to relate to that. And the parents in this focus group did say that face-to-face was always the preferred option. But it was considered that GP appointments, for example, are regarded as quite hard to come by. And therefore, the online information allows for that peace of mind, particularly in those non-urgent circumstances, and where reassurance was really important for them. And I've also listed some of the most common topics that parents were searching for online, which we'll come on to a little bit later in Karen's section. Next slide. Thanks, Katie. So with all that said, we know that access is still a very real issue for a lot of families, which is an ongoing issue that our consortium partners are seeing amongst their communities. And many of the barriers that came up on our insights work echo the barriers that have already been discussed already within the previous sessions. You know, thinking about confidence, language barriers, motivation, you know, so I won't go in and repeat on those, but I think a key point to pull out here, I think, is particularly when we're thinking about removing those barriers, the fact that community-led organisations are seen to be meeting people where they are, often doing the work to support people to get online, supporting the navigation of online information and services. They've built a really strong level of trust with families. So they're working with them, their trusted individuals, signposting them to trusted information, and this is felt to be appropriate and for meeting their needs. And there was real synergies with this that came up from our practitioner survey that we facilitated, and we asked a key question, which was, you know, if there's one thing you could change to improve access to healthcare for digitally excluded families. We had responses that called for more support in the local settings, like community centres, for example, to help anyone that needs support in accessing services online. And also more volunteers, so those based in settings to promote the information that's available online, showing families how to access them. And that it's too often that people are excluded, often in multiple ways, and they don't even realise that they're excluded, and they're really missing out on the opportunities or just don't know how to access them. I'm going to hand over to Karen. He's going to talk through some more practical examples of how we're using insights and the importance of input of parents and carers in the ongoing development of our Barnardo's digital offer. If we move to the next slide. Thanks, Katie.
Are you there, Karen? Can we hear you? Oh, yeah.
I'm here, but
There
I don't know if you can see me.
we can now. Yeah, brilliant. Thank you.
Thank you. Well, hello everyone. I'm Karen Moulton. I'm the team manager for the Barnardo's Family Space. And our family space increases access to parenting and caring advice, allowing families to find support at a time and a place to suit them. This helps to eliminate health inequalities and provides choice and frees up appointment times. Content has been developed and quality assured by our internal team of clinical experts and by external associates to ensure robust, consistent and high quality information. Barnardo's Virtual Family Space is a digital platform that provides parenting support whilst overcoming geographical and time constraints. It aligns with both the Family Hub specification and the Healthy Child programme and offers, as you can see on this slide, 3 tiers of support. Tier 1 is our universal open access website for parents and carers, and you can see some stats on the screen there. We know most of the families that access this service are using mobile phones, and all content is written with this in mind to help with readability, and all images have alternative text to allow for screen readers. Our Tier 2 work is the professional support online, where parents and carers register on a platform to access facilitated courses, workshops, seminars and e-learning. You can see our current offer there. We work closely with our colleagues in face-to-face settings to enable access for families should they not have the tech to access themselves. We refer to this as a hybrid delivery, where facilitators are on screen and the parents and carers are in a centre or family hub. And our Tier 3 one-to-one targeted support is where parents and carers can book one-to-one appointments online, and you can see our current offers there. If I could have the next slide, please, where I'll go into each tier in more detail. So our virtual family space, our universal open access website, QR code there, which I would invite you to actually access if you're able to do so. Our website is ongoing and needs regular updating and maintenance, and new material is being added regularly. We work alongside a parent panel with diverse needs who provide invaluable feedback on the look and feel of the website from the parents and users' perspective. This has included those with their own learning needs and also who make use of screen readers and have other visual disabilities. Next slide, please. Thank you.
Sorry.
That's okay. Our Tier 2 is our professional support online. It started in October 23. Delivery of this was focusing on the first 1001 days of a child's life. We tweak and iterate as we progress through the 1001 day pilot, including changing the name from 1001 days, as it didn't actually mean anything to the families themselves, to Best Start in Life. The pilots are being delivered in 3 areas, Plymouth being a city, Surrey Heath a town, and Westmoreland and Furness a very rural area. Families in attendance are aware the courses and workshops are being attended are part of a pilot and are asked if they'd be willing to participate in one-to-one interviews and feedback. And this has all helped with our understanding of what works and does not. The majority are attending through their mobile phones from either their own homes or whilst out and about. The service enables them to access support at their own convenience and comfort. And from the feedback in our one-to-one interviews, we've learnt how facilitators recognise the need not to hide behind presentations and are more present on the screen. This is more nurturing and enables families to engage more and feel comfortable to participate. We enable different interaction, quizzes and discussions to take place. However, should a family be accessing the service from their mobile phone, if this is their only gadget, they cannot also access, say, a quiz from a QR code. So facilitators manage this by making use of links and the chat function. Facilitators also follow up the delivery by emailing attendees their resources. The content, weaning and teething were mentioned earlier in Natalie's presentation from our past consultations as priority areas, and this has been included in our delivery. Next slide, please. So our tier 3, on screen here you can see some examples of work that were designed to address some inequalities. Our Brent out of hours helpline, staff were recruited with the skills to overcome language barriers in a trauma-informed way with the families in contact with the service. Evaluation data has shown us that the service is engaging with groups who may be at risk of health inequalities and poorer outcomes, including those who are new to the area, those who are living in temporary accommodation, and those for whom English might not be their first language. 48% are saying that English is a second language, and 23% of calls to the helplines have been from dads. Our online infant feeding team is another of these examples, and the local team have been very flexible and agile in their approach, developing different aspects of the service model, including different virtual groups and a successful training programme for staff working with new mothers in prisons, and making use of prison staff technology to engage with the prisoners and varying the content to allow for safeguarding protocols within the prison mother and baby units. Next slide, please. And that is our last slide. So thank you, Katie.
Wonderful, some fantastic examples in there, so they're brilliant, thank you. And some good data as well. Yeah, we see a large proportion of the people who use our services through our network have English as a second language. It's a massive part of the whole digitally excluded population and something that needs to be thought about carefully. Brilliant, thank you. So just to summarise some of the themes that we've heard, and then we'll move on to some questions. So I think that one of the key things that we've heard throughout all of the presentation is that the barriers to digital inclusion are fairly common, but certain groups experience some of them more extremely than others, at a higher level than others. And it's really important, therefore, based on the point that we gathered from yesterday, to really understand your audience, to get to know them and understand what their most important barriers are that you need to address. Again, digital services can be really useful. They make services more accessible to those that may otherwise be excluded and can help with tracking of symptoms, treatment, advice, all of that kind of stuff. It can play a really great role. But also to think about staff and community support for your digital services. They may need training, resources, funding to make your service a success. So it's not as simple as just building it and people will come. You have to build the support around it. Fantastic. So Q&A, I am going to put contact details for people on the screen so you can get in touch with people should we not get to your questions. And I'll hand over to Jo to run the Q&A.
Great, thank you very much, and thanks to those of you who put some comments and questions and reflections into the chat space. The first question it sort of builds on a point I think that Jamie raised in your presentation about hospice care, but it's been picked up in another question as well. But there are a wide variety of digital platforms and digital tools that are being used across health and care services. This might be overwhelming for service designers, like understanding which are the best tools to use and how to make that selection. But also, Jamie, as you picked up, that it can be very challenging for people if they're switching between providers of care, for example, between the system used by their GP to the system used by a hospice care provider, that in itself can be very difficult, even if people do have the digital access and some digital confidence to engage. So I might pose this question to you first, Jamie, and then open it up to other people. But what can be done about that? How can we make it easier for people to shift between different digital platforms? Or is there a way we can try and refine the options that are out there that are being used across the health service?
Yeah, it's a really good question, Joe. And I don't have a complete answer for that one at the moment, I'm afraid, in the sense that I strongly suspect that the number of digital platforms will increase over the next few years rather than actually decrease. And for very understandable reasons, NHS trusts or hospice care providers will have made decisions on the platforms that they want to use in their organisation for, very many different but equally valid reasons. From my point of view, and I say this as somebody who comes from more of a web background than possibly a healthcare background, I think it is developing those services with the user in mind to make it as seamless a transition from one platform to another, so that if somebody knows how to use one platform in particular and they're confronted with the prospect of having to change to another platform to access somebody else's care or support or information, that it is not an overwhelming jump for them to get from one to the other, that they can feel that there's a similarity in the design, in the ease of which they can sign up for a particular platform, that they feel welcomed on that journey. Now, obviously, when I look at that and look at the example of the Hospice UK website, there are many different ways in which we provide information and support, as organisations have had to confront over the last few years. And you start with the user in mind and think, how is the end user going to be impacted for the better by this service? Even to the fundamental question on a more wider generic note of, should it be a digital service, or is there another way in which it's best delivered for that user? You have to make it, I think, as fundamental as that. So I appreciate this is world-class sitting on the fence from my point of view in terms of saying, how do you conglomerate people into, say, one platform? I don't think that will happen. But I think for those people that build those platforms, I think it is mostly about trying to make sure that you don't intimidate the user from the outset and make it a welcome experience for them, so that they don't feel that using several different platforms is a scary thing for them. Because, as I say, there are obviously many good reasons and very valid reasons why organisations would have picked the platform that they have chosen.
Thank you very much, Jamie. Karen or Natalie, do you have anything to add from your perspective in terms of supporting families to navigate between different sources of care?
I mean, thinking about this in the context of the insights that I shared, so perhaps not answering the question around how do you navigate the many similar platforms and choosing perhaps, but I think often I've talked about how community-led organisations are very well placed to signpost families to services, resources, that kind of thing. So can we think about the ways in which we provide those professionals with the information they need to explain what the service is to families? And the way that I often refer to that is, activation. So you can give our community groups a leaflet, but actually, do they know how to talk about what they're offering and to talk that through with a family? So I just think really make use of these, keen and eager individuals who really want to signpost their families to resources that are going to support them by providing them with what they need in order to do that. So something for a call out for those who are developing the tools and the resources to think about the wider comms and how they want to influence how this is being communicated across different communities.
That's great.
I'd just like to jump in and add to what Natalie's just said, that one of the things that we've actually used in our family space is we've actually created an animation which actually explains that process as well in very simplistic terms. And I think that can be quite engaging as well, because it's an easy thing to watch. It's actually an AI version of myself, which is quite scary, but it's helpful.
Great, thank you, Karen. And I think
Jo, if I
yeah,
could
go
come
ahead,
in
please,
there.
Jabir. Yeah.
What Jamie and Karen and Natalie have pointed out is all very useful. But I fear there's another issue here, which is one of choice. At the moment, what we seem to be doing is heading down a path where digital first not only means digital first, but actually means digital only. And I think what lots of communities are, including those communities that experience inequality or are at the cutting edge of inequality, is they want a choice. They want to be able to choose whether they enter services through a digital platform or through a face-to-face contact with practitioners. And I think that's what we're losing sight of, is that if we don't give people choice, we then have the potential of exacerbating inequality rather than easing it or improving it.
Yeah, that's a really, really good point. Thank you, Jabir, and speaks to there's a question in the chat box about how do we hold people to account about these widening inequalities and the potential for digital to exacerbate those inequalities. How do we at the highest level influence there to be a strategy that really helps us to limit reduce the inequalities and certainly not allow digital to exacerbate them. Any final reflections on that rather big question?
Jabir, do you want to come in? I was just going to point to the framework that the NHS England have developed on mitigating the risks of digital exclusion, and the strategy they've developed. I think it's a good starting point. It's, you know, it requires people to then adopt it, implement it well. I think also many of the points that we've raised, it's about standing on the shoulders of others. Look at who's doing it well and learn from them. You don't need to start from scratch on all of this stuff. There are some good examples out there, as we've heard today, and so there's some great knowledge and insight in the sector to help you build them well. So don't feel like you have to do it alone. Do it with others on top of, you know, and build on others' experience and expertise. We've got loads more on that tomorrow in terms of design, and I'm sure I would love to kind of give us more time to talk about some of this stuff, but we had only scheduled it till kind of 1:45 this meeting, so I want to give people time to run off to other meetings. So apologies to cut all of those amazing questions short. So Jo, do you just want to quickly do the poll and then we'll just draw it to a close?
I will do. Yeah, thank you. As I said before, we'd just like to do a quick follow-up poll of 2 of these questions, just to see if what you've heard today has shaped your knowledge or confidence with thinking about improving digital inclusion in healthcare. So you should see the questions on your screen now. Leave that up for a minute or so.
While you're doing that, I will say a massive thank you to all of our speakers today. It's taken a lot to get all of this together, and in the time that we've had available to do it, keeping to 10 minutes I know is really tricky, but you'd all did an amazing job. So thank you so much for contributing. Thank you for all of those of you who've attended, and I hope it has been useful. As a reminder, we have another session tomorrow, so if you are already registered, brilliant, but if not and you would like the content, we will share that afterwards. And shall we close the poll? It seems to have stopped going up in terms of numbers. Have a good rest of day, everyone, and thank you so much.